Hi, everyone, and welcome to Greenspace's first session in partnership with Dr. David Clark on the power and impact of measurement-based care. We are thrilled to have over 600 clinical leaders and clinicians register for the session, which is absolutely incredible, and I think is a good indication of the growing interest and implementation of measurement-based care, which is obviously fantastic news for the future of mental health services. My name is Jesse Hayman. I'm the Chief Growth Officer at Greenspace Health, and I am beyond honored and excited to be able to work with Dr. Clark on these two sessions. He is a global leader when it comes to mental health service delivery, and even more so around his focus on using measurement-based care to inform and improve treatment outcomes. Before we get going, I want to start by thanking Dr. Clark for taking the time to share his wisdom with all of us. And I'd like to thank all of you for taking the time out of your day to join the session and learn about the impact of measurement-based care with us. A lot of attendees here are familiar with Greenspace, coming as clinical leaders or clinicians from organizations that we work with, but many of you are brand new to Greenspace. So as a quick intro, we are a mental health technology company focused on helping clinics, hospitals, and health systems implement measurement-based care across their services to better understand their impact and improve their overall quality of care. Greenspace was founded about 7 years ago out of a major research hospital, focused on bridging the gap between what we knew about the impact of measurement-based care in research and its practical application in a clinical setting. While the research is compelling, it wouldn't see widespread implementation without making the process much more simple and automated for clinical leaders and clinicians. And that's where Greenspace came in as we set out on a journey to build technology to make the implementation of measurement-based care easy, to reduce barriers to implementation, and provide clinical value to both clinicians and their clients. If you fast forward to 2023, we work with over 400 partner clinics across US and Canada that are implementing measurement-based care across a very wide variety of unique programs and populations. All that said, with any big change in any industry comes a very real need for education. There'll always be a need to build awareness in general education. But with innovation, there also is concerns and questions that come from people within the industry, which is completely understandable. And that's why Greenspace has been very focused on educational content surrounding measurement-based care, which really comes to life in two ways. One is consistent written educational content, and the other is educational sessions with some of the foremost leaders in the mental health space, but also the measurement-based care space. So prior to this session, we held a 3-panel series with the Yale Measurement-Based Care Collaborative that was attended by over 1,200 people across the 3 sessions, and more recently hosted a discussion on the Therapeutic Alliance with Dr. Brent Mallinckrodt, the co-author of the BRWAI, as well as psychotherapist Emily Miller. Following on all of those, I'm thrilled to get into this session with Dr. Clark. So let's move on to the person you'd like to hear from. I have the pleasure to introduce you to Dr. David Clark, who was and is one of the key leaders behind the NHS Talking Therapies program, which is formerly known as IAPT, which has set the global standard for mental health service delivery across the health system. In addition to being a world-renowned applied psychologist and expert on measurement-based care, Dr. Clark is the chair of experimental psychology at the University of Oxford, the clinical informatics advisor and NHS Talking Therapies, and co-author of Thrive, the Power of Evidence-Based Psychological Therapies. Throughout his career, he has received numerous awards, including Lifetime Achievement Awards from all of the British Psychological Society, the American Psychological Association, and the American Association for Behavioral and Cognitive Therapies. The latter describing his work as pure genius with a real-world application, and I could not agree more. So with all that said, thank you for being here, Dr. Clark, and I'll pass it to you for a few opening remarks to everyone in attendance.
It's just such a great pleasure to join you all today, and I'm looking forward to our session thinking about how we can advance measurement-based care in our different countries.
2 quick housekeeping items before we move into the action of the session, if you will. One is at the bottom of your screen, either depending on how wide your screen is, you'll see a Q&A button. If not, it'll be in the 3 dots that say more. If you have any question for Dr. Clark throughout the session, please press the Q&A button and input it there, not as a chat, not in the chat. You'll also see there's a bit of a thumbs up. That is an upvoting feature. So if you like one of the questions submitted, please upvote it, and we'll make sure to prioritize at the end the questions that most people want to hear. And then secondly, there'll be a survey that pops up at the end. That survey is to help us inform future sessions, including our next session with Dr. Clark, which is taking place on October 12th. And it's going to be a more of an Ask Me Anything Q&A style discussion, which will be, the questions will be informed by what we aren't able to get to here, as well as questions that come up in the survey and when people register. So please feel free to throw your questions in the Q&A. And if you have a few minutes at the end to fill out the survey. So that said, let's get into it. Over the past 15 years, and the NHS Talking Therapies, or formerly known as IAPT, has been tremendously successful and has transformed the way that millions of people access and engage with mental health services. I personally think it's a shining example of how we can drastically raise our expectations of mental health care and deliver a much higher quality of service. At the same time, it puts us in a place where 5 to 10 years from now, we can look back and likely see immense progress that has been made due to a change in approach today. So I'd love if you could share a general overview of the program and the key goals you set for it early on.
Great, thank you very much, Jesse. Well, I mean, the real key aim of the program was to deal with an injustice. So in most countries, the majority of people in the community with anxiety and depression get no treatment at all. And among those who do get treatment, it's much more likely to be medication than psychological therapy. But there are numerous surveys that have asked the public, would you have a preference between an effective psychological therapy and effective medication? And although some people say, yes, please give me the drugs, in a ratio of about 3 to 1, the surveys show that the public would prefer psychological therapies. But really nowhere in the world is the public getting what it wants. So the aim of the IAPT program was to reverse that in England by firstly training a large number, currently 10,800 psychological therapists in national evidence-based psychological treatments recommended by NICE, and making sure that the training allow people to achieve the relevant competence standards to deliver the treatment. So your competence is assessed by videos of your sessions with patients, and then deploying them in efficiently structured step care services for anxiety and depression, providing all of the therapists with regular, that means weekly, clinical supervision, and also ongoing professional development opportunities. And then critically, and rather radically at the time, aiming to measure and report the clinical outcomes of all the patients who receive a course of treatment, a sort of unique exercise in public transparency. Of course, when we're reporting patient outcomes, it's not the outcomes for an individual patient, but it's the overall outcomes for a given service. And we also set a target for the services, which is that if the treatments were delivered well, we would expect at least 50% of patients to fully recover from their anxiety and depression, and many more, of course, to show worthwhile benefit. And it was based on strong economic and clinical arguments, which we'll come to later in the session.
Awesome. Thank you so much for that, Dr. Clark. You stole it out of my mouth in regards to getting to the economic piece after. It's awesome to hear about just the goals that were set early on, and also understanding, looking at your data, understanding what you've achieved so far, which is incredible. Obviously, there is a significant change management piece that has come with NHS's implementation of measurement-based care and the overall program, from clinician engagement to making sense of and responding to a massive data set. Could you talk to us a bit about how you approach gaining support for such a large and innovative initiative across the UK?
So because this is in the English National Healthcare System, the first group to talk to was actually the Treasury in the government to see if they would allocate money, and they decided that they would do, based on an economic argument. But then when you're working with clinicians, we realized that the overall aims of the program were very ambitious, to really get people to commit to giving evidence-based treatments. Not everyone agrees to that. And also to commit to recording the outcomes of all of your patients and reporting that. Not everyone agrees with that either. So rather than transform the whole system in one go, what we decided to do is create a small number of services following this model in a few areas of the country where people were particularly enthusiastic about trying it, and collect the data from those early adopters. And then if they achieve the outcomes we expected, which they largely did, then we encourage other services to come on and adopt the similar principles. And so we sort of gradually grew over a 3-year period to cover the whole of the country. The other thing to say is that there's so much undertreatment of anxiety and depression that we didn't try and replace our existing services. We said there's lots of scope for something additional. So at least in the beginning, we added this on top of existing services, which made it, I think, much easier not to get into any tensions with existing provision and gave us a chance to really show our worth.
Awesome. Thank you very much for that, Dr. Clark. I think what rings true to me is just the for lack of a better term, starting small. Obviously, in your case, small is relative towards the whole of the UK. But we have so many organizations, whether it's a large clinic or even a small clinic of 15 or 20 that sometimes want to start with a smaller group. I think one of the biggest things that comes from it, which I'd imagine you've experienced as well, is that you figure out challenges that you wouldn't have expected on implementation, that when you're in that small group, allows you to work it out with that small group prior to maybe it's a phased rollout or a full rollout, that helps inform just the overall implementation strategy.
Absolutely. I mean, it's invaluable.
Awesome. Thank you. So when IAPT started, or when NHS Talking Therapy started, you set a lofty goal for recovery rates. What did you want to achieve then, which you've covered a little bit? And then I'm curious if you could share a little bit about what has happened since.
I think you can see that on this slide. So we started small, at least relatively speaking. We treated 98,000 people in the first year, but we've now grown to be treating around about 670,000 people a year. We see more than that. We see about 1 million, but when you assess people, not everyone turns out to have anxiety or depression, or the problem is mild and they could just benefit from some straightforward advice. But we end up with that 670,000 people that we give a course of treatment to. And once we've started a course of treatment, so once you've had an assessment and at least one session, then we commit to recording your outcomes. And we use a simple session-by-session outcome monitoring system to make sure that we do get data from you, even if you don't turn up to your last session, for example. We can take how you're doing at the previous session. That system has worked really well. We do get outcome data on 99% of that 670,000 people. Waiting times before we started this were long in England, but they've dropped to an average of just 20 days before you start treatment. And the clinical outcomes now are broadly in line with our expectation from the research studies and our target, which was 50% recovery. And you can see that on this slide here, where we've plotted years into the program, and then the red line is the recovery rate. So the first thing to notice is that we were quite a bit short of our target in terms of recovery in the first couple of years. And if we hadn't been collecting outcome data on everyone, I guess we'd still be in that position and blissfully ignorant. But 100,000 or so patients would not be benefiting each year if we stayed that way. So, but because we were collecting data on everyone, we were obviously able to spot quite a lot of variability in the outcomes of our different services. Some were already the 50% outcome target, others were way below. And so we studied the differences between the services, fed that information back into the services, and they sort of innovated on the basis of that information. As you can see, we steadily improved our outcomes. And then for the last 7 to 8 years, every year, we've been at our target for over 50% of people recovering. And the dotted line shows the number of people, or the proportion of people who've shown really substantial improvement, reliable improvement. That's obviously a higher figure still, pretty close now to our 70%.
Thank you so much for that, Dr. Clark. You've accomplished an incredible amount in the last handful of years, and I think that's a significant understatement when you look at even just the few data points you just shared. You have 1 million people accessing services, a massive reduction in wait times, drastic improvement in recovery rates, which obviously signals a much better quality of care. But going back to my earlier comment, I think when you get started with measurement-based care, you're going to see immediate results from some people that are going to benefit from having access to their data, understanding their mental health better. Clinicians have a better idea what people are struggling with, and that might be an immediate piece that you see right away. But the drastic improvements you're talking about in recovery rates, I think, take longer, where you can actually dive into that data, build the data set, and that sort of thing. So going back to my earlier comment, where you'll be in 5 years, I think the most powerful piece is that you have data on 99% of individuals accessing care, and the ability to be then curious about that data, understand and respond to gaps in care, puts NHS in an incredible position to make impactful service improvement, and I would say continue to innovate as the gold standard for evidence-based care. So jumping into that, now that the program has been running for well over a decade, are you able to share some of the key impacts and insights that you've been able to realize thus far?
So, I mean, the first thing was picking up on what you were saying, that some of the services were doing a lot better than others early on. And so as we have data from them all, we could look at that and see what are the features of the services that are doing really well and compare them with the ones that are not doing so well. And we published that in an article in The Lancet a few years ago. And some of the key differences were, firstly, the services that were doing really well gave a higher average dose of treatment. So it's just like in medication, there's a dose response effect. But the optimal number of sessions, the average number, was not enormous. It was about 10 sessions, although obviously some people get many more, some people get less. We also find that how long you wait before starting treatment was important. So those services which on average could get you started in your treatment within 6 weeks at maximum, got particularly good results. Those that had a longer average wait before the start of treatment, although they were offering essentially the same treatments, the outcome rates were not as good. So it seems that there's a sort of moment of opportunity we have. I think coming for psychological treatment is quite a challenge for people. They know they're going to have to discuss some difficult things. They're going to have to work with their therapist quite hard on those issues. And I think when they're referred, they're open to that. But that's a window of opportunity which won't always stay there. So that's our interpretation of the data, at least. The other thing is, it does seem very important to follow the clinical guidelines. So early on, we had quite a lot of therapists who were aware of the clinical guidelines, but would do something slightly different from the clinical guidelines sometimes. And of course, because we have the data, we can look at whether patients benefit from that slight difference. And we found in general, they didn't. So, for example, NICE recommends counseling and cognitive behavior therapy for depression, and we got identical outcomes for the two. But for generalized anxiety disorder, NICE recommends cognitive behavior therapy, but not counseling. But many of my counseling friends said, but we know we do well with patients with generalized anxiety. They were right in the sense that we got 48% of people with generalized anxiety to recover with counseling. But what they didn't know was that with cognitive behavior therapy, it was 58%. And we found this many times, that following the guidelines in terms of evidence-based treatment gives us better outcomes. And that compliance is now much better in the system, of course. We also found that some services have quite a lot of patients who have a scheduled appointment, but then don't turn up, what we call DNAs. Those services, again, had less good outcomes, but we could change that really quickly by encouraging them to use SMS reminders for appointments, and then their DNA rate went down and their outcomes went up considerably. And the last key feature was doing a good assessment, and we found that those services that were good at identifying the key problems they're going to treat get much better outcomes.
I want to ask a quick follow-up question to that last point you made of people, like when you identify the right thing to measure. Could you dive into that a little bit and just explain what you mean by that in regards to I'm assuming freedom to some of the clinicians to like customize measures in order to match what that person is looking to improve
Well,
on.
yeah, so the first thing we found is that the clinical guidelines depend on your diagnosis. So it's very important for clinicians to be clear on what that is. And in England, we use the ICD-10, but in the US and in Canada, you probably use DSM-5. So it would be identifying that relevant code. And then, as we'll see a bit later on one of the slides, it really helps if you then use a measure which tracks the particular symptoms that are characteristic of that particular anxiety disorder, say.
Got it. And I think that's the next question, and we'll pop that slide up. But you mentioned that you reviewed patients that were discharged, but not fully recovered. And that is a focus of the data set, which makes complete sense in regards to how to improve our outcomes overall, or your outcomes overall. And by diving into that data, you were able to identify some common themes that help inform changes to the approach to care for that subset of individuals, which saw impressive results. So I'm curious if you could tell us some about what happened there.
So, so the first thing I was going to mention to you was really just sort of in an open-ended way, probing to see if we can identify the people who don't do well. So with a massive data set like ours, and it's now 7 million people who've been treated, you can look in a way which is quite replicable at, is there a sort of combination of people's personal characteristics and clinical features which predict a poor outcome? And so we've been doing that. A chap called Rob Sanders has done what he calls latent profile analysis, where he's identified a subgroup of people who have very low recovery rates, only about 20%. When you look at that subgroup, there isn't any particular diagnosis that they have, but they do tend to score high on measures of both depressed affect and anxiety. They tend to be unemployed and on welfare benefits, and they tend to have some phobias as well. Once those had been identified, then we got the algorithm that you use to identify that subgroup and ran it on all new patients coming into the services around the Oxford area where I work. And we got together with the clinicians and thought, is there an improved offer we could give these patients? And we thought, well, one of the obvious things that's missing is the help of an employment advisor who works very closely with the psychological therapist to deal with the employment issues and also some well-being issues. So we offered patients who met the sort of latent profile 7 criteria this enhanced therapy if they would like it. Not everyone took it up, but for those people who did take it up, the recovery rate really improved enormously, up to 47%, really pretty much with the national target. For those who didn't take on the employment advisor as well, it was lower at 27%. And this is not a randomized control trial, which would have been ideal, but we have statistically controlled for every single confounding variable we could think of, and we still get this effect. So we feel we have found a way of creating something new for people who wouldn't have benefited at all well before. That's analysis by Graham Chew here in Oxford. And then I think, Jess, you were mentioning about the particular measures you take, and it turns out that's pretty important for guiding treatment. So we have 2 general symptom measures. We measure how depressed people are with the PHQ-9, and we have a general measure of anxiety, which I think many people will be familiar with, the GAD-7. If you look at the items on the GAD-7, it really covers how worried you are and how anxious you're feeling. And it is quite sensitive to improvement in all different anxiety disorders. It goes down as the anxiety disorder gets better. But it does have a limitation. And the limitation is that it doesn't have any specific items to do with PTSD, for example. It doesn't measure intrusive memories of painful events. It doesn't assess difficulties with social interactions, which is relevant to social anxiety. It doesn't assess obsessions and compulsions. And for panic disorder, it doesn't actually record panic attacks. So we've encouraged therapists in the services to use what we call anxiety disorder specific measures. One's particular for PTSD or panic, etc. And what you see on this slide is an analysis where we've compared the outcomes when your therapist is using the specific measure to help guide treatment versus when a therapist is not doing that. Of course, we have to be fair and use the same outcome metric each time. So the recovery rate is, are you below the clinical threshold on both the PHQ and the GAD? And you can see your therapist being aware of the key features of your problem that's being treated and using it to guide treatment makes an enormous difference to recovery rates, PTSD from 32% up to 53%, and the same sort of difference across the board of all these anxiety disorders. And it's not just symptomatic improvement. If we also measure how disabled someone feels by their mental health problem, and again, you get this big difference. So it's not just a matter of recording outcomes on a regular basis, you go through treatment, but it's about choosing a measure which helps the therapist to stay particularly focused on the key features of that problem.
Thank you so much for that, Dr. Clark. We have 4 C's, we call them, for Greenspace, and it's really the 4 most important pieces of measurement-based care implementation. And one of them is customization, which I think speaks precisely to this, which is the idea that, let's say you're working within an eating disorder programs and you use 2 specific assessments. In this case, let's keep going with PHQ-9 and GAD-7. And you also realize that this person is struggling from a functioning perspective in a very real way. And that's what matters to them in care as well. Maybe that's something they're looking to improve. One of the biggest parts that influence the success of measurement-based care is that your client is engaged. If they don't find value in it, you may struggle to get assessments completed and that sort of thing. So that therapist, it would be important for them to maybe add on, let's say, the WSAS, so you can have an understanding of functioning. One, you now have a much better understanding of what your client is working through, but the client in care can start to understand themselves better, advocate for themselves in care, communicate around what their needs are and what they're experiencing. And in that way, build therapeutic alliance, obviously a fantastic predictor of success in care. So I think that customization piece really stands out to me as such an important feature around what you're talking about.
No, I fully agree. I mean, it's a very perceptive comment.
We can talk about the benefits of routine measurement. I think the point I just made about you needing the client to be engaged and see the value in what's happening is a big piece of making it successful. But when you talk about routine measurement, if it's too difficult to collect assessment results, that collection is just not going to happen. So I'm curious, in your experience, how large organizations or networks, or in your case, across an entire system, how you've made consistent client-reported data collection easier or consistent?
Yeah, really good question. So I think the first thing to say is you really want it not to be a burden to either staff or patients. We don't want to waste any valuable therapy time collecting outcome measures, so we collect them outside of the therapy sessions. And the way we do it at the moment, it's evolved over time, is a very straightforward one. You'll get a text message with your appointment time, and it has a web link in the message as well. You click that link and you can fill in the measures on your mobile phone if you're a patient, and it goes direct into the IT system of the service. And then when you come for therapy, you can see graphs of your progress on each of the measures with your clinician. So there's no data entry by the clinician, and it's pretty straightforward for the patient. The other thing, though, is to train your clinicians to make use of outcome measures in order to guide their therapy. Because our general experience is that the people who are most skeptical about outcome measurement initially are not the patients, they like it, it's the therapists. And so they have to see it's not just some arbitrary admin exercise or some sort of audit, but rather that when they look at the particular items on the questionnaires, they can spot things which help them focus what they're doing in the next session of therapy. So there's a sort of real clinical training there. And of course, it's also very important that patients feel that if they're going to go to the trouble of filling in these measures, they're really being used in therapy. So, if a patient fills it in, it's really important that the therapist mentions that they've seen the questionnaire, they have a quick look at the graph together. And if things have gone up, they might look at, well, what's been going on in the last week? Why do you think that is? And play that into the therapy itself. It greatly improves the therapeutic relationship. There are also various behavior incentives you can have to increase data completeness, but perhaps we might come back to that in the Q&A if someone's interested in that.
I think one of the biggest things that stands out for me that you just spoke to, which is the clinician finding clinical value in the work that they're doing.
Yes.
Is the fundamental difference between what's been happening with measurement in the mental health space for the last, let's say, 30 years, where a pre-post would be considered measurement, but the pre-post provides no clinical value to the clinician, so it's viewed as a reporting exercise, where insert measurement-based care, you flip that on its head by measurement-based care first and foremost being about providing clinical value. And if you're not providing clinical value, you won't be successful. So that need for sharing back to the clinician and the client what that data is looking like, automatically visualizing it so they can use it to inform their session, is what measurement-based care starts with. And that's the foundation that I think has been missing. And it's also maybe why clinicians are hesitant when they've been asked to do reporting exercises time and time again in the past, but haven't seen the value in that. Whereas measurement-based care, I think, flips that on the head. And I think it's a really positive side of why you might see hesitation initially, but also why you see engagement once it gets going.
Yeah, I think that's right. So we find that to get that right, you have to get the leadership of these services right. It's very important that clinicians don't feel that these outcome measures are being used as some sort of administrative, harsh performance management type system, but rather that the outcome data helps you as a service and you as an individual clinician to spot those people that we're not doing quite so well with at the moment and think more about them, reflect on them, and see how we can improve things further. So everyone gets into mental health more or less because they want to help other people, because they want to improve the health of their patients. And so it's really important that people see the outcome measurement as a real good way of them achieving their original goals for getting into this job. And so in the services that do it really well, they work together, the different clinicians. They have projects where they focus on particular groups of individuals or that they don't feel they're doing so well with, and then try and innovate with those, and then look at the data and see if it improves. And that really brings people along with the initiative. And it seems like, you're in an exciting, innovative service rather than being harshly performance managed.
Awesome. Thank you so much for that, Dr. Clark. You had shared on a call we had a couple of weeks ago, just the idea that in that process, you may, 4 months, 6 months down the road, look at a data set and collaborate on it together. And that's going to help your clinicians and your clinical leaders understand how the value of the data and how it's going to be used to disarm people. I think one of the things you said that just stood out to me was that is very clearly communicated early on around how the data is going to be used once we have it, what that process will look like, so that disarming doesn't take 6 months or a year for them to see what that process looks like, but they can understand it from the beginning. I know that's one thing that stood out to me.
Absolutely.
Jumping into our next question, we think it's vital for people's care goals to be at the heart of both treatment approach and decisions. And obviously measurement-based care and having data really helps us do that. A key part of that is by making the assessment results available to them, they can learn about their own patterns. They can better identify what may be impacting their mental health positively or negatively, and also help them develop a shared language so they can communicate their needs and care, which also helps us drive more equitable care. Because regardless of someone's background, they have an opportunity to develop the language necessary to communicate their needs and advocate for themselves within that care session or with that clinician. We've seen that giving people agency keeps them engaged as well and leads to symptom improvement and a higher therapeutic alliance. Across 400 implementations, clinical implementations on our end, there is a step ladder that is pretty much look the same from a data perspective across two areas. One is therapeutic alliance, that the more assessments someone completes, the higher their therapeutic alliance, which makes sense. There's more alignment around what you're looking to improve and how things are going in care. And then the other is symptom improvement, that the more assessments someone completes, the better that they do in care. And that's regardless of the program that they're in, where they started at. And again, that is not a clinical trial, but it's just looking at our aggregate data and seeing that same step ladder that you would have seen in the research side of things, but in actual implementation, in actual implementations across so many different settings. So I'm
those
curious.
Very exciting results. Yeah.
Yeah, absolutely. I think it's extremely exciting. And I'm curious if you have any thoughts on just the importance of the client visibility side into results, because we often talk about the clinician and their visibility, but I'm curious your thoughts on the client side.
Yeah, so we really make a point of sharing with the client the sort of graphs of how things have progressed during therapy. And, we get a lot of feedback from the clients about the outcome monitoring. And they very consistently say that they really love seeing those graphs. And they often, will look at them and say, oh, God, I thought nothing had changed, but I look at this now and I see actually, I was a lot worse when I started. I see that in the last couple of weeks, things have been, going back up again. I hadn't really thought about that too much, but now I do think about it. There are these things that have been happening, and these have knocked my confidence. Maybe we can talk about those in therapy. So I think the clients feel it gives them a much better insight into what are the determinants of their mental health, what's working, what isn't. And so they feel empowered, I think, to have more of an equal relationship with their clinician, where the two of them are working together as a team to work out how to overcome these mental health difficulties. So it certainly helps the alliance, but it also gives patients a lot of insights that they can capitalize on.
Thank you so
much. You don't get that if you just do pre and post treatment measurement. All of that is gone. You only get it if you're doing regular measurement within the course of therapy.
Well, and on top of that, you lose the why. It's very hard to say why someone has changed over a course of, let's say, 3 or 6 months, because there's so many factors that play into that pre-post scoring. Whereas every 2 weeks, actually, you still may be in a position where you're not quite sure what changed, but you're in a great position to be able to say, hey, let's talk about this one thing that did change and try to identify what impacted it, whether it's care, whether it's things at home that are impacting your overall symptoms, whether it's a positive or a negative change. With our focus at Greenspace, like completely around implementing measurement-based care with clinics, hospitals, and the health system, every employee, and I think I shared this with you a few weeks ago, at Greenspace is gifted yours and Richard Layard's book called Thrive. While I was very much aware of the impact of measurement-based care before reading Thrive, there were many aha moments, if you will, around the impact that the proliferation of measurement-based care would have on the quality of care for each individual accessing support. And many pages for me, which are like folded at the top, that I go back to remember a few of those arguments. So I'm curious, because in Thrive, as well as various articles you've authored, you make compelling arguments about the cost of mental and physical health care, a positive impact that improves services through improved mental health services through the use of measurement-based care can have on overall cost of care. So I'm curious if you could share some of the key insights from an economic and ROI perspective that can help attendees as they think about and advocate for measurement-based care.
Sure. So the economic bit of the argument was really critical to getting the whole program going. And I'm pleased that, some of it has come through in Thrive. Which bit of the economic argument you use depends a bit on the audience. So my experience is that with politicians, then the key argument is that untreated anxiety and depression shrinks the size of all of our economies by about 4 percentage points. That's an awful lot of money being lost to the US and Canadian economies. And it's unnecessary because these are treatable conditions. So that gets the attention of the politicians. But if you're looking at healthcare providers, then I think the first really key point is that if you can effectively treat anxiety and depression, that very substantially reduces your other costs of physical healthcare. So around about 40% of people with anxiety and depression also have a long-term physical health problem, whether it's cardiovascular disease, obstructive pulmonary disease, asthma, diabetes, and the cost of managing those physical conditions is about 50% more on average if you have anxiety and depression. we can largely remove that excess cost by treating the anxiety and depression. And we've got quite a lot of good data on that. That's sort of reducing your current costs for other healthcare. Some really exciting data recently has also shown that we can reduce your future healthcare costs as a provider. So there's a beautiful article just recently appeared in the European Journal of Cardiology, which followed people up who are treated in NHS Talking Therapy services over the next 3 years and looked at new onset adverse cardiovascular events. And they found that those people who had recovered from their anxiety and depression in the services had a reduced rate of any adverse cardiovascular event, including heart attacks and strokes. So this is really a very big saving in future healthcare costs. Of course, one reason why people go for psychological treatment as an argument rather than medication is because of the well-demonstrated fact that relapse rates are lower after psychological treatments than medication. So that's another saving in healthcare costs. But if you're a provider who is providing a healthcare service to a large company, which many of you will be doing, there's another bit of the economic argument. And that is that successfully treating anxiety and depression means that your workforce is more focused on the work. One of the big problems with someone who's anxious or depressed is while they're at work, they're often not really present. Their mind is on their worries and their concerns, and so they're less productive in the workplace. And so helping them with their anxiety and depression reduces what technically is called their presenteeism, makes them more effective in the workplace. So that's another big economic benefit to the companies that you're providing healthcare for.
Thank you so much, Dr. Clark. We had one other question before we're going to get into the audience Q&A on the future of NHS Talking Therapies and where you'll be going from here. I'm going to make the executive call to skip that for this session, just based on our timing, because I want to make sure we have as much time as possible for the audience questions. And we'll add that as a maybe standard question for next time, so we can get into that, because I'm very curious, as I'm sure many attendees are. First of all, I want to thank everyone for submitting what is a massive, it's got to be 25 plus questions. So we're only going to be able to get to a few, but this will be super helpful for us to look at, see which ones are similar, and also to inform the Q&A style session next time, which will be based on what you're all curious about. So I'm going to start at the top. There's a question from an anonymous attendee with 11 upvotes, which is the most. In adding this measurement-based care on top of existing services, did your outcome measurement replace or complement previous measurement practices?
Yeah, so in England, the tradition in mental health was to measure things like how many people got treatment and how long they waited. So if you like, sort of supply side variables, but we didn't have a consistent system for collecting whether people got better. I mean, services were trying to do that with some patient-reported outcome measures at the beginning and end of treatment, but we found that nationally, the best we could do with that was only about 40% data completeness. So we were missing data on 60% of people. And one of the key early findings of the NHS Talking Therapies program is that when you have missing data, you delude yourself about how good your service is, because we found that on average, the people that you have missing data from are the people who've done less well. So it didn't really replace something. It created something that we didn't have, or at least we didn't have with a degree of completeness that's useful.
That's super helpful. Thank you for that, Dr. Clark. Next question is, do clinicians record the data as part of the session? You answered this a little bit already, so we'll see what overlap there is, but do clinicians record the data as part of the session, or do they have to enter the data at a later time?
Yeah, so we don't want clinicians to waste valuable therapy time, filling in questionnaires with the patient or getting the patient to fill it in while the clinician's waiting. So we tend to get patients to fill in the questionnaires before a session starts. And it used to be on sort of pencil and paper questionnaires, which they would complete and give to the receptionist, who would then enter it into the IT system. But now we have more of an electronic system. We send a reminder to the patient about their forthcoming session. It comes up on their phone, and there's a link that they can click, a unique link for them, which takes them in to the questionnaires, and they just press the little buttons on their phone to say how badly they felt depressed and things. And that data just automatically goes into the system. So it's really a pretty zero burden for the patient or the clinician.
Zero burden with the added benefit of you having a lot more information heading into that session without needing to do anything on the collection side, which I think we have this question come up all the time with like a fear of burden on the clinician. And I think if you weren't doing any measurement before, there's not much additional burden. That person will then be able to jump in right before a session to see what the data is looking like. If you have been doing measurement before, it's probably actually a significant a significant reduction in burden for that person, because you no longer have to do that collection, whether it's paper and pen, as you explained, or in session with that client. So I think that's been a big piece, is to your point, how can the technology help us make sure there is no burden and it is just clinical value that the clinician is seeing?
And of course, the advantage of it going automatically into the IT system and being filled in advance is one which really helps motivate patients, because of course it means right at the start of the session, you and your patient can see the graphs. You can see how they've been progressing, so they get immediate feedback and a chance to think about it. Whereas, if it's being filled in the session and then it gets graphed later, then you don't get that immediate feedback, which patients really love.
Awesome. Thank you so much, Dr. Clark. I'm going to combine two questions here. The original from Dr. Tammy Mark. What is Dr. Clark's opinion on the role and value of patient experience of care surveys and psychological treatment? The follow-up question from Dr. Larry Epp is, why did the UK choose to leave out patient satisfaction and therapeutic alliance? What was the rationale?
Yeah. So we think patient experience is very important, and we haven't left it out, actually. So it is in the NHS Talking Therapies minimum data set. And we have two patient experience questionnaires, one that people fill in after their initial assessment. And it really asks questions about whether you felt you were understood in the assessment, whether people listened to you, and whether you felt your clinician had a good understanding of what your problems are. And whether you got clear ideas about what the therapy approach would be. And then we have another patient experience questionnaire that people are given at the end of their course of treatment, which indicates how satisfied they are with the therapy that they've received, with 5 different items. So we think this is very important. It's an important voice for patients. It's not just have your symptoms improved. The clinicians are very interested in that. Have other measures of disability improved, but did you think it was a good experience is very important. The difficulty, I think, in the field with measures like this is that sometimes patients can feel a bit of pressure to report good, because the therapist is going to see it, and they don't want to upset the therapist. The therapist has been trying hard. So we do this in a way on the electronic system where the patient is told their therapist won't see the individual patient experience questionnaires. They can see, how they've done in general with their patients, but it is essentially a confidential report back. I think that's really quite important if you want to encourage patients to be able to say negative things as well as positive things. And actually, it's the occasional negative thing which is most informative for our practice.
Thank you very much. First of all, I realized the most upvotes wasn't sorted properly, so I now have the most upvotes. We did answer some of the most popular ones, but I'm going to try to fit in a couple more with the remaining time that we have, at least 2. One is, what is Dr. Clark's theory on why 50% recovery, why you chose 50% recovery from their symptoms? Should that be considered a universal rule of thumb for benchmarking? Why was 50% picked as the threshold for success?
Yeah, so it was pretty arbitrary. So the program is a public promise, which says that if you come to this program, you will get the psychological treatment that is recommended by our National Institute for Clinical Excellence, NICE, for your condition. It might be CBT, it might be interpersonal psychotherapy, it might be brief psychodynamic psychotherapy, it might be counseling. We support all of them for particular conditions. Actually, sorry, where was I up to on the question?
You were explaining that the 50% was somewhat.
Yeah, so why did we get 50%? So the first thing that I did, because I'm responsible for the 50%, was to then look at all the randomized controlled trials that NICE had reviewed for its recommendations of treatments, and look at the outcomes that were achieved with the therapies that seem to be doing the best in the trials. So not all CBT is the same, for example, and then estimate, if we look at the relative prevalence of the different anxiety disorders and depression, if we did as well as all the clinical trials, what should we get? And that, my estimate, was about 60% for recovery. So we knocked it back by 10%, thinking a mass implementation project probably will lose a little bit of effectiveness compared to gold standard clinical trials with very experienced therapists. So that's how we got the 50%. So a bit arbitrary. And so I wouldn't say it was a gold standard, but what I was very proud of is that our minister agreed to set that as a target. Quite a lot of the civil servants said, "Oh, don't mention that. Sounds like it's going to be very difficult to achieve." But setting a target was really very important. To anticipate Jesse's question about where we're going next, we do now know we can go further. So we have quite a lot of data which shows that we can get nearer 60% full recovery and a higher reliable improvement rate. And so I think that is going to be one of our aims in the next few years. And in our Q&A, I'm very happy to share with you all the data we have, which suggests we can do that in particular conditions and why we're pretty confident about it.
Awesome. Thank you very much, Dr. Clark. I want to ask one more question, but we need time to wrap up. So if you could do it in 1 minute,
Okay.
This is something that comes up quite a bit around people's nervousness around completion rates, both on the client and clinician side. And this question is, please talk about what are some behavioral incentives to increase adherence to use. And I think that's on the clinician side, but I'd be curious your thoughts on that.
Yeah. So one is getting the right leadership so that you feel that even if the results aren't very good, it's going to be viewed in an interested way within your service, not in a critical way. That's really important. And the other behavioral incentive was to do with how you report outcomes. So when we report the outcomes for a service, we don't report the recovery rates based on the people that you collected data from. We report it on the whole cohort of people that were treated. And so if you didn't collect data, we report that there was no improvement. That removes pretty much any incentive for a service not to collect data on everyone.
Awesome. Thank you very much, Dr. Clark and Speedy. A huge thank you to you for being here. It was an absolute honor to host this session with you. And to the clinical leaders and clinicians that are in the room with us, thank you for taking the time out of your busy days to learn from Dr. Clark and participate in this discussion. I think the notion of the growth and proliferation of measurement-based care is easily illustrated by the 600 plus clinical leaders and clinicians that have registered today. That blew our hope of 300 registrants out of the water. So thank you for that. As I mentioned, our next session with Dr. Clark is set for October 12th. You'll see an option in the survey to register for that. We'll also send registration next week along with the full recording of this panel. A reminder that a survey will pop up shortly. Please take a second to fill it out if you don't mind. And otherwise, just one last massive thank you to Dr. Clark. It's been an absolute honor. And thank you all for attending. And we hope we'll see you at the next session on October 12th, which will be an amazing discussion and your questions answered. And there's so many to work off of. And as always, if you're ever thinking about implementing measurement-based care at your organization or system, please reach out anytime. And we hope to see you at the next session. Thank you all so much.
Yeah, and it's been such a pleasure to participate. I can see there are enormous numbers of questions. really good questions. So I'm looking forward to us getting into them in the follow-up session, and a good summer for everyone in between.